If you look in the literature, it's very little data describing this condition with a malunited stiff shoulder. There are no randomized studies, there are no good clinical studies with large volume of patients. But we know from the literature that there are certain features in a malunited fracture that is correlated to poor function, and one is varus deformity. And in our own study with the phylus plate, we found that an angulation of less than 115 degrees was correlated to worse outcome. So varus should be avoided. Valgus malunion is better tolerated. It doesn't really give that much stiffness. Furthermore, posterior angulation of the head is correlated to worse range of motion. And also malunion and greater tuberosity has a negative impact and may result in stiffness. And you may see stiffness, of course, in a fracture setting after conservative treatment and also after surgery where you have maybe not achieved an anatomical reduction or you have a secondary displacement. And it's important if you see these patients with stiffness and the malunited fractures to get the correct data, to look in the charts, whether they have done any revision surgery, if they had a wound problem, has been an infection, because that is something you have to deal with if you intend to treat it. So the first thing, I think it's important to analyze the patient's complaint. And if you have a patient like this, the first, of course, is pain. Normally, if there is no pain, but you have a severe deformity, my feeling is you probably should avoid doing an arthroplasty or something because there is no pain. Stiffness, as we heard, it's very important to analyze the problem properly, looking at active and passive range of motion. And also weakness, because the function of the rotator cuff will guide you in the treatment algorithm. And also look at the patient. What are the functional demands of the patient? After the clinical evaluation, it's time to do some radiographic analysis. And I think plain radiographs in connection with a CT scan and 3D reconstruction is very useful. And the CT can be used to analyze the bony deformity, but you can also get a good view to see the condition of the rotator cuff, whether there is fat infiltration or atrophy. And I rarely use MRI in these patients. This is an example where you have a patient with a malunited greater tuberosity fracture, and with a CT scan and plain film, you can see the degree of malunion, and you can also look very nicely to see here the rotator cuff, the volume, the fat infiltration, the atrophy, to give you an idea how the motor is functioning in the shoulder. And then you combine the clinical finding and the radiographic analysis to see what is the stiffness due to. Is it a soft tissue problem? Is it a bony restriction? Or is it a combination? And then look at the articulation. You have to see whether the articulation is okay. Is there any osteoarthritis? Or is there any incongruency? Is there any avascular necrosis? What is the position of the joint surfaces? And it is very important, I think, to really look at the soft tissue as well as the bone, because the long-standing malunion almost always affect the rotator cuff, and the treatment then depends on both the bone and the fact that you lost the function of the cuff. Like in this case, where you have malunion, but also severe atrophy of supraspinatus and the whole posterior cuff. What are the treatment options then? Well, first, of course, continue rehab, which is usually the first step, to give the patient intense and active rehab program. The second thing you may consider is an arthroscopic release. The next is open release and hardware removal. And then you go down to more complex procedures like osteotomies, removal of osteophytes, or arthroplasty, where you have to make a decision whether to do an anatomical arthroplasty or a reverse. Now, if the bony anatomy is okay, like in this case, where you actually you achieved good anatomy. But if the patients complain about stiffness and pain, then you analyze it. Usually a soft tissue problem, it may be the gliding surfaces, and you may treat that if it has been like a greater tuberosity fracture that has healed nicely. You can deal with that with a subacromial injection and rehab, or if that's not solving the problem, arthroscopic release. If you have more complex fracture and the anatomy is okay, rehab of course, but then arthroscopic releases can really be beneficial to gain motion. And if there has been an open procedure done, I usually don't do the arthroscopic releases, then I remove the hardware and do open releases. If the bony anatomy is not okay, you have a more complex problem. And then you have to consider osteotomy or combine osteotomy with arthroplasty. If the joint surface is okay, there is no osteoarthritis, I think osteotomy, particularly in a young patient, should be the goal. If there is a combination with osteoarthritis and malunion, like in this case, then of course you need to do an arthroplasty as well as releases. And it's important to remember, I think, that if you do an arthroplasty and combine it with an osteotomy with greater tuberosity, that has a negative impact on the results. But if you do it in combination with reverse, it does not affect the results to the same extent. The most common type of malunion that I see with stiffness is actually a greater tuberosity fracture that has healed with a displacement, and that can be successfully treated with an osteotomy where you do a small deltoid split, you open the rotator interval, define the fragment, and you do the osteotomy, and you can create a raw surface with a burr and attach the greater tuberosity in a lower, more anatomical position. And you don't need to do any releases of the capsule. Once you correct the anatomy and you do the rehab, the function will return. The surgical neck osteotomy is when you have usually a varus and posterior angulation of the head fragment, which creates a malunion and poor range of motion. The investigation, as I said, CT, and then you do the osteotomy and fix it with a plate. And even in these cases, capsule release is not needed. As soon as you correct anatomy, rehab will solve the problem. This is an example where you have such a deformity, varus posterior angulation. You see plain film doesn't really tell you all the data, but on the CT scan you see how much deformity the patient has, and very poor range of motion, active and passive. And you correct that with an osteotomy, it heals, and the patient, with no releases of the capsule, restore normal range of motion when you correct the anatomy. In a more complex malunion like this, of course, osteotomy can be considered, particularly in a young patient, but it becomes more difficult, and there is always a risk that you jeopardize the vascularity of the head. But it may be worth trying in younger patients, like in this case, where we actually did a 4-plane osteotomy, all the tuberosity and the head fragment. But in older patients today, the reverse arthroplasty, maybe with combination osteotomy, is the method of choice. And if you look at the series of deltas or reverse that we have, we see now from 2006 of over 300 reverse, about 1/3 are trauma-related. So it has become a fairly large group when it's time to restore function in these complex malunion and post-trauma conditions. So in summary, if you have a malunion with stiffness, I think if you have an anatomic healing, it's much easier to treat. You can do the arthroscopic release, soft tissue procedure, as you heard about. The first step for me is always to try intense rehab. Otherwise, arthroscopic or open release, if anatomy is okay. Osteotomy can be a solution for a selected patient, and it can give good pain relief and improved range of motion. The more complex malunion usually results in poor cuff function, so you have to deal with the fact that the function is not working in the cuff, and then a reverse has become an important tool, particularly in the elderly. Thank you.